You hear an optometrist talking to a patient called Marcia Samarina. For questions 13 to 24, complete the notes with a word or short phrase.
Now, Jane, just before we begin, can I start by asking you your age?
I'm 25.
Okay. And what brings you in today, Jane? What's the problem?
Well, I've been feeling a bit tired for the past few weeks, and I don't seem to have much energy to do anything, really. And I was wondering if you could tell me what's wrong with me.
Okay. Well, tell me a little bit more about it.
Well, I started to get tired about 4 weeks ago, and it's really persisted since that time. And I've actually had to stop playing netball because I've been so tired. When it started off, I had some aches and pains in my muscles, and but they seem to have settled down now, and it's really just the tiredness that's persisting. And I've got exams in a few weeks, and I'm really worried that I won't be able to study properly because I'm feeling so tired.
I see. Goodness, that must be very distressing for you.
Yeah, it's really worrying me.
Yeah. What are you studying?
I'm a social work student.
I see. Well, tell me, apart from the aches and pains that you noticed initially with this illness, was there anything else in particular that you'd noticed?
Well, it sort of started quite suddenly, really, and when it started, I had a bit of a cold, a bit of a blocked up head and a runny nose, and I actually went to the doctor at Student Health at the university, and he said I just had a virus and I didn't need any treatment and it would go away, and he didn't do anything else than that, really. Right,
okay. So at the moment, just to let me clarify again, the main problem now is tiredness. All of the other symptoms have settled down.
Yeah, just really tired, and I can't do anything, really.
Right, okay. Well, just before I actually start examining you, can I ask you a few just general questions before we get started, okay?
Mm-hmm.
What's your appetite and weight been like?
My appetite's been fine. I've been eating the same amount, and my weight's steady.
Okay, and have you been running any fevers recently?
No. 4 weeks ago when I had a bit of a cold, I thought I had a bit of a temperature then, but nothing now.
Okay. And your bowel habits?
I've been regular.
Regular, that's good. All right, well look, I think at this stage I'd like to have a bit of a look at you, and we'll talk about things after that, okay?
All right.
Right, Jane. Having had a look at you, I think really the major things that are noticeable are that you've got some scattered glands around your body. Okay, those lumps that I felt in the neck, armpits, and down in the groin regions, and you may have also noticed a bit of discomfort up in the left side of your abdomen, high up, when I was feeling. And that is the site of an organ called the spleen, which is also a type of gland which is also enlarged. Okay.
So what does that mean?
I think all of these really point to some form of viral illness, quite possibly glandular fever.
Okay. I was just going to ask as well, are you absolutely sure it's glandular fever?
It's highly suggestive, okay. I can't be totally certain at this stage without really doing some tests to confirm it, and I think that would be a good idea to do.
What sort of tests are they?
It's a blood test, and it will involve a small sample of blood being taken. Really, what I'll do is do a specific test for glandular fever, as well as looking at your blood in general to make sure that there are no other possible problems there.
And that can tell for sure if it's glandular fever?
Yes, that's correct.
Right. And when you do the blood test, can you see if I'm anemic as well?
Yes, certainly. Is that a particular concern of yours?
Yeah, well, I've been having all those ads on the TV, about if you don't eat enough meat, then you might be anemic, especially if you're tired. And I was wondering if that was my problem as well.
Okay, I mean, tiredness certainly can be one of the symptoms of anemia, and I think it's justified that you're concerned about it, particularly given the publicity that we've been having. But I can fairly confidently reassure you, just on having examined you, that that would be very unlikely in your case. Okay, but we can certainly run that test, and in fact I was going to run that test as a routine anyway.
Oh, that's good.
Right. What you need to do really at this stage is rest. Okay. There are no specific remedies that I can give you for this illness. We can't cure it. Your own body will cure it by fighting it off, but that will take a bit of time. How long exactly? Again, I can't be certain. Hopefully within the next week or two you'll be feeling a lot better, but that's something that we're going to have to keep an eye on. At home, really, you need to keep up your diet and keep up your fluid intake, and really we're going to have to organise to meet again and just make sure that this is slowly settling with time.
Extract 2 questions 13 to 24.
You will hear part of a consultation between a GP and a patient called Mr. Martin.
For questions 13 to 24, complete the notes with word or a short phrase.
Hello, Mr. Martin. I'm Dr. Hampton.
Hello, nice to meet you.
And you? How can I help you?
Well, I've come about my stomach. I've had problems with it over the years, on and off, but at the moment it seems to be worse again. Mainly kind of just real sore feelings across here.
Okay. When you get the pain, where is it exactly? Can you show me?
Yes, it's here. It's sort of across the upper part of the tummy and down here to the middle of the tummy.
And how would you describe the pain? Could you put words to it?
It's more sore. I can't say it's a real pain. It's more a sore feeling and like irritation, maybe?
Right. Does it move around or is it always in the same place?
Yeah, I mean, sometimes. It always seems to start here in the middle, kind of. I can feel a bit there now, but I've had it more down each side as well, and I didn't know. At one point I wondered whether it was my kidneys or something, or whether it's still the same thing. I don't know.
Okay. And you said it's both sides. Do you mean together, or does it sort of flip from one side to the other?
Yeah, not together. It goes from one side to the other.
So it really moves around, this pain, doesn't it? Do you get bloated when you get the pain?
Yes, very bloated.
And can you tell me how long this has been happening?
Well, I first had it several years ago. I had it when I was working, and a doctor I went to see said then it was probably irritable bowel. That was 4 years ago.
Right. Was the bloating a part of that too?
Yes.
And did things settle down for a period of time?
Yeah, they settled down when I was watching my diet much more, and when obviously I wasn't as stressed. I'd given up work.
Okay. What about your bowels? Can they be a bit variable?
Yes, very much so.
Could you tell me a bit more about that?
Well, I've always had a bit of a problem with constipation, mainly. But I mean, I'm going just recently going perhaps a couple of days and not really going. And then, like, in the last couple of days, every time I eat, I seem to want to go.
Right. And are you getting loose motions?
It's loose, yes.
Right, okay.
Yeah, I mean, really, nothing has changed. I mean, I drink loads of water, but when I'm constipated, it's really hard and just like, like small brown pieces when I go. And then when it's loose, it's a bit ribbony. I've always had a bit of a ribbony movement.
Yes. Is it true diarrhea or not?
No.
No. Okay. Have you passed anything unusual looking? Any blood or slime or anything strange?
No, I haven't.
Haven't passed black motions as far as you know?
No.
When you had the IBS before, what sort of things did you do for it?
I think Dr. Dorsey gave me some Colofac, is it? Or something like that?
Yes, that sounds right. Was that helpful?
Kind of. Because she explained to me about a kind of a spasm thing. But I just kind of watched what I ate again. I mean, it's probably worse if I don't go to the toilet. And so, I try to eat things and, to make sure I do go without taking anything, without any laxatives of any description. And then I know it's probably really old-fashioned, but I take peppermint oil. The capsules? And I think they're actually really helpful.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best, according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear 2 nurses conducting a patient handover. Now read the question.
Mrs. Garner's a 73-year-old who came in because of an exacerbation of COPD. This is day 3. Today she's down for a repeat chest x-ray, and that's all booked in, and her leg dressings need to be done. She has bilateral ulcers. Oh, and you'd better chase up the report on her sputum sample. We should have had that back by now.
Okay.
There's a history of ischemic heart disease and type 2 diabetes, peripheral vascular disease and peripheral neuropathy. She's been treated with IV antibiotics, steroids and nebulizers. She's mobile with a walking frame but gets breathless. She's down as high risk for falls.
Sure. I'll continue to monitor her fluid intake and check that she sticks to the diabetic diet.
Great.
Question 26. You hear a GP talking to a patient. Now read the question.
So, shall we have a look at your blood test result? So, what we're testing for is the level of hemoglobin in your blood. And just to show you, the normal range for women is between 11.5 and 16 grams per deciliter.
Oh, yes.
And this is your level of hemoglobin. It's 8.7.
Oh, I see.
And what this tells us is that you're suffering from iron deficiency anemia.
Oh, yes. I thought that might be the case. That would account for the lack of energy and the, lethargy. I think that's what you called it last time. So, perhaps I need to look at my diet, increase my iron intake?
Well, what I'd like you to consider is taking a course of iron tablets. This can be a really effective treatment for the condition, and what it does is it supplements the amount of iron you're getting in your diet.
So, does that mean I can go on eating normally?
Not necessarily. I think we'd better run through what that phrase means in your case before I answer that question.
Okay. Question 27. You hear a senior nurse briefing a colleague about working in the recovery room. Now read the question. Okay, so this is the recovery room where you'll be working. Patients come here directly from theatre. It's their first stage recovery before going back to the ward. Here we have a monitor, and on that you can see all the patient's vital signs from theatre, okay?
Right.
So you check that it's on and functioning, attach the BP cuff and pulse oximeter, and you're ready to make your assessment. The system then prompts you in terms of what to do next with the patient.
So, do they get extubated in theatre?
It depends. Mostly they do, and that's ideal. But sometimes it happens outside. If they come out with an ET tube in place, then it's probably because the doctors want to keep it there during recovery. But if it's a laryngeal mask, then the anaesthetist will see to that. We just have to ensure that the patient's kept stable. Question 28. You hear a dentist talking to a patient. Now read the question. Okay, so today I'm going to prepare the tooth for the fitting of the crown, then take an impression.
Oh, really? I thought I was having the tooth filled. Have I got the wrong end of the stick then?
Okay, well, if you remember, last time you were here, we discussed the various options for the tooth because there's already a big filling in it that's fractured.
Yeah, and I thought you said you'd be replacing the metal filling with a tooth-coloured filling made out of some sort of composite material.
Oh, yes, I see. Actually, what we discussed was either a new metal filling, which may or may not stand the test of time because there's going to be a lot of stress on what's left of that tooth, or go for a tooth-coloured crown instead, which would be more robust.
And is that what you quoted for in terms of the price?
Oh, yes.
Okay, let's go for it then.
Question 29. You hear a triage nurse in the emergency department talking to a doctor. Now read the question.
Excuse me, Doctor. I'm getting concerned about one of the patients I've triaged this evening. He came in with pain in his right shoulder going down the arm, and I put him down for an ECG and blood work. But he's now saying he feels feverish, and he's asking me how long it's going to be before you can see him.
I see. How long's he been waiting?
Around half an hour. The thing is, he's got an infected wound on his leg. Says he's had it for a while, and it doesn't seem to want to heal. He didn't tell me about this initially. I've looked at the wound, and there's clearly inflammation and some discharge. But what's worrying me is that his speech is getting rather slurred, so I'm concerned that it might be sepsis. I think we should move him up the list.
Okay. Thanks for flagging this up. I'll take a look at him straight away. Question 30. You hear an eye surgeon briefing some new staff at the eye clinic. Now read the question. of the biggest challenges for us can be deciding what's normal and what isn't. Looking at the back of people's eyes, as we do all day, what strikes you is the enormous variety of shapes and sizes you see there. The optic nerve may be oval, it may be round, or it can be irregular in shape, and all of that can be perfectly normal. So we get lots of referrals, particularly of children, where an optometrist observed something a bit funny at the back of the eye, and they want us to check it out. Well, that's fine. If they err on the side of caution, that's better than missing things. And from our point of view, it's all worthwhile. After all, it's only by looking at a great many healthy eyes that you learn to diagnose the problems that we need to deal with.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear a sports physiotherapist called Chris Maloney giving a presentation in which he describes treating a high jumper with a knee injury. You now have 90 seconds to read questions 31 to 36.
Hello, I'm Chris Maloney, a physiotherapist specialising in sports injuries, and I'd like to present a case study to give you an idea of the sort of work I do. It features a very successful high jumper in her mid-20s who was referred to me with severe pain in her right knee, and that's the leg she takes off from when she jumps. What's more, when she stepped up her training in preparation for a big competition, the pain worsened, and she'd been forced to pull out of the event. After that, she'd taken several months off training to rest and get treatment from various therapists. To her dismay, however, not only did the pain continue, it actually got worse, meaning she was unable to do any strength training, let alone jump-specific work. By the time I saw her, she was on the verge of giving up, having lost virtually all belief in her ability. My initial assessment quickly confirmed patellar tendinitis in the affected knee, accompanied by some swelling and significant tenderness over the lower part of the kneecap. This wasn't difficult to diagnose. I also noted that she was slightly overweight for her height and had rather flat feet, but that's not so unusual in high jumpers. Further assessment revealed that the gluteal muscles connecting the hips and thighs were considerably less sturdy than you'd expect in an athlete of this calibre, and both the lateral retinaculum connecting the patella to the femur and the iliotibial band, the ligament running down the outside of the thigh, were tight and tender. As a first stage, I was keen to show I could help by relieving some of the pain, so I worked at loosening her lateral retinaculum to see how much of the tendon pain was due to inflammation and how much came from restriction of normal patellar movement. This manipulation and massage instantly cleared the pain she'd felt while doing a single-leg dip exercise, where you stand on one leg and bend the knee. This indicated that her tendon pain was most likely due to patellofemoral joint dysfunction, caused by muscle imbalance and poor biomechanics, and not by an active inflammatory process or partial tear in her patellar tendon. So an MRI scan wasn't needed. The treatment continued along similar lines for some weeks, with loosening of the lateral retinaculum and deep tissue massage of the iliotibial band and other muscles. One option at this point was something called taping. This is a way of reducing pain so that athletes can continue with strength exercises. But it seemed clear from early on that we shouldn't put taping on this patient's patella and tendon until she started jumping again. She was getting pain relief and progress simply from the manual techniques, and taping might have led to problems later on. Athletes often become dependent on tape and other accessories. In other words, instead of aiming for 100% muscle strength and joint position control, they settle for 80% plus artificial support. The patient also had a specially designed program of gym activities. Although she needed to restore power to those muscles affected by inflammation and tenderness, the priority was to get her posture and alignment right. She started by doing double leg squats with her back to a wall in front of a mirror so that she could see whether her feet were arched and if her knees were over her feet. She also did squats while squeezing a ball between her knees. There was light leg press work, followed by single leg stance work, first static, then on wobble boards, and with elastic resistance. She progressed to moving on and off steps, sometimes holding weights, all the time paying close attention to positioning and muscle and joint alignment. The next stage was to liaise with the patient's coach. She began running, jogging for stamina, and then sprint sessions. Work on power was stepped up gradually and included some weightlifting. After some analysis, we also decided to modify her run-up to the high jump bar. By beginning from a wider position and running in with much less of a curve, there was much less of an impact on the ankle, knees and hip, especially in her right jumping leg. Interestingly, the patient reported that remodelling the run-up felt fresh and motivating and helped to reinforce the sense she had of being a reborn athlete. Once the rehabilitation process was complete, she was able to compete without pain and free of any reliance on taping or knee strapping. So, before I go on to the next...
Questions 37 to 42. You will hear a plastic surgeon called Norma Woolston giving a presentation about surgical treatment for a condition called Dupuytren's contracture. You now have 90 seconds to read questions 37 to 42. My name's Norma Woolston, and I'm talking today about surgery for a condition called Dupuytren's contracture, with a particular reference to a case I treated recently. Dupuytren was first described by a French physician of that name in 1834. It's a condition in which one finger becomes increasingly bent in a flexed position. The first sign is a formation of small hard nodules in the palm of the hand, but early diagnosis is relatively unusual because there is no associated discomfort. In its early stages, the condition may respond to steroid injections and physical therapy, but this doesn't necessarily halt its progression. The affected finger often becomes increasingly bent and can no longer be straightened. But patients tend to present with the condition only when manual dexterity is compromised, by which time surgical intervention is indicated. My patient, let's call him Eric, presented with quite an advanced case of Dupuytren's affecting the little finger of his right hand, a relatively common site for the condition, although a physical examination revealed that he was also developing the first signs in the thumb on the same hand. Eric was then a 61-year-old office worker who used a keyboard regularly. There isn't very much published so far on the causes of the condition or what might exacerbate the symptoms, but the digital age doesn't appear to have resulted in an exponential rise in the number of cases reported. Eric was finding the condition inconvenient and uncomfortable rather than painful. It was becoming tricky shaking hands with people, and holding a pencil was becoming a challenge. Eric didn't recall any family history of Dupuytren's. That's not unusual, but doesn't in itself mean that there was none. Indeed, we know that the condition is often present across the generations of one family. But because patients don't typically develop symptoms until late middle age or later, it often goes undiagnosed or doesn't develop to the point where it requires treatment. Indeed, mild symptoms are often attributed to mild arthritis or the general effects of aging and wear and tear. Nor did Eric report any of the other associated risk factors, such as smoking, diabetes, or low body mass index. It's worth noting, however, that he was of classic Northern European appearance, tall and fair-skinned, and Dupuytren's is known to be much more common amongst Northern Europeans than in other populations. In Eric's case, the condition had progressed to the point where surgery was indicated. It was clear to me that what was required was a fasciotomy to straighten the finger. Eric had some misgivings about this, as he'd heard about less invasive treatment options. But I explained to him that, taking into account the extent of development of the diseased tissue and the specific site, This was the only option, and he agreed to go ahead with the procedure. Fortunately, Eric was generally in good health, was taking no medications for other conditions, and had no concerns or negative history relating to general anaesthetic. This was much the preferred option because, although the surgery isn't lengthy, usually between 30 and 40 minutes, it does call for a complete immobilization of the hand. After the procedure, Eric was using a sling and pillows at night to hold the wound side high up and so prevent a build-up of fluids. I'd explained that wearing a sling when out and about also provides a degree of general protection. It's a remarkably effective way of signalling to other people to keep their distance, as the hand is very sensitive to knocks. But actually, he'd taken plenty of time off work, so this hadn't been a problem for him. Indeed, when I saw Eric at the follow-up appointment, the wound was healing well. His notes showed, however, that the sutures hadn't all fully dissolved after surgery, and that this had been a source of discomfort. Worried that perhaps there was an infection, he'd consulted a nurse, who'd removed them and also taken the opportunity to excise some excess scar tissue, which had formed at the site. I reassured him that this was by no means unusual and wasn't a cause for concern. I was pleased to see that when he returned for the final consultation, Eric's wound had generally healed well. As is the case with many Dupuytren's patients, however, Eric volunteered that, despite my careful explanation at our first consultation about the treatment and recuperation period, he'd entirely underestimated the impact of the surgery on his daily life and how long the disruption would continue. That said, his finger is now much straighter. This treatment for Dupuytren's never completely straightens the finger, nor restores full use, but he'd been aware of that from the outset and had no complaints on that score. So far, apart from the initial indications in his thumb, there is no sign of recurrence, although this is relatively common, especially over time. I reflected, however, that perhaps being very familiar with the condition and having performed this kind of surgery many times, I hadn't made it clear enough to Eric exactly what to expect after the surgery. What Eric's case made me realise